Okay. Thank you, Speaker Chairperson. Dear friends, this is exactly the topic that Dr. Vijayakumar gave me. I have not changed it. Adipocyte, what to know. Now, traditionally, adipocyte was thought about as an organ which just stored energy in the form of triacylglycerol. That's it, nothing else. But the concept has changed now. It has three functions. It not only stores lipids, but it is associated with storing as well as breaking up the lipids. So it's lipogenesis as well as lipolysis, which is dependent on insulin sensitivity. So if it depends on your insulin resistant state, either you'll have lipogenesis or you have lipolysis or both. And third, it is now considered as an endocrine hormone because it secretes endocrine hormones like ghrelin, like resistin and adiponectin. So now it has three functions. Now why is adipocyte important? I remember first when drugs were coming into our country, like Orlistat and others, people used to say, why is it coming to India? People are here with all ribs exposed and look at them lean and thin. Why obesity drugs should be in India? Look at where we are today. Obesity prevalence in adults more than 18 years of age. This is the global data from the World Heart Foundation. And this is 2020 data. You find that the global obesity prevalence is 18%. India, and it's published in 2020, is 40.3. Now this is from our very recent analysis, which is still going on. We have 3 abstracts in ESD, Dr. Sheshadri, Dr. G. Vijayakumar, all part of this data, from 33 centers all across India on CKD. Look at the data we have. BMI more than equal to 25 by Indian and Asian standards. 57 point, near about 7% patients are obese. Now if you include overweight along with it, only about less than 22% of our patients are having normal weight, or some of them are even underweight. So this is the major problem. Now, when we talk about adipocyte, we have been traditionally taught about 2 types of adipocytes, white and brown adipose tissue. Now we have 4 types of adipose tissue. It depends upon the color or hues. We have the white, which is the largest bulk and largest volume. We have the brown adipose tissue, also called the hibernating adipose tissue, because it is associated with non-shivering heat production. It's found mainly in the supraclavicular and the thoracic regions. We have the beige. The beige and the pink are nothing but transdifferentiation of white adipose tissue under certain circumstances. The beige one is associated because it protects from obesity and from cardiovascular outcomes. And pink is predominantly expressed, or transdifferentiation happens during lactation and pregnancy. Now, since white adipose tissue is the bulk of the volume, I'll stick my presentation with white adipose tissue. Now, first is adipose tissue is concerned with lipid. So there are 2 aspects of lipid management. One is lipogenesis, another is lipolysis. Now in a basal condition, when we have adequate carbohydrate in our system, not surplus but adequate, then we find that the de novo lipogenesis is more in the liver than in the adipose tissue. But the minute we have excess carbohydrate in the system, it gets reversed. We have more lipogenesis happening in the adipose tissue than in the liver. Now here comes on top of it insulin resistance. So if you have insulin resistance, this storage is defective because the fat cells cannot enter into its storage sites. So you have increased fat in circulation. So you have increased free fatty acid in circulation due to insulin resistance. Now the other side, lipolysis, which is cleavage of triacylglycerol. So you break it into di, then you break it into mono. Each time you break, free fatty acids are released into the system. Post-meal, insulin goes up and stores the excess carbohydrates and excess fat into the system. But again, if you have insulin resistance, you have a problem because you cannot store it. So here what happens is the lipolysis also doesn't take place adequately. As a matter of fact, you have increased free fatty acid in the system in the backdrop of insulin resistance and obesity, both because of defective lipogenesis as well as lipolysis. The second is endocrine. It releases 3 hormones, leptin, adiponectin and resistin. Leptin is the good one, and it normally protects from obesity and also has a positive energy balance in the system. Resistin is just the opposite of it, but the most important hormone, which has been the target for the last 20 years, there's even a kit has come out recently where adiponectin, hsCRP can be measured together, but it's still not coming into the market because adiponectin is a very difficult molecule to replicate either as a therapeutic or as an investigative purpose. But adiponectin is hyper or is expressed more in our system in a normal state, and it goes down whenever we have carbohydrate and this protects against cardiovascular outcomes from cardiovascular disease states. This is the normal adiponectin expression in the basal state. It is expressed, the highest expression is out there. And today it's considered to be the holy grail of cardiovascular risk reduction because it is inversely proportional to expanding fat volume. And we are now in a state of expanding fat volume, all of us. So adiponectin is going down. Is there some way in which we can increase its expression? Then one of the best ways definitely is losing weight. But if we can't, if there's any other therapeutic aspect, this is where all the data is going on. Where I worked in with Professor David Owens, that's a lab which has patented this particular kit, which has adiponectin, HSCRP, as well as proinsulin, which will be assessed in the same kit. But it is still stuck somewhere. There's a patent issue and many other issues. It's stuck somewhere. Now, it's not only the volume. It's not only that I have this amount of adipose tissue in my system. The issue is, where is it? Where is adipose tissue? It can be deposited in subcutaneous space or in the visceral space. Now, this is the red line, which is most important. Any fat accumulation, whether it's subcutaneous or whether it is visceral, if it happens above the red line, both are harmful. If it happens below the red line, well, obviously below the red line, you don't have visceral adipose tissue or visceral space. But those are subcutaneous space where the fat accumulation is not harmful. Now, with aging, and remember, this is another area of focus. Today, metformin has completed 2 trials, MILES and TIMES trial. These are anti-aging trials. SIRTUIN is another molecule, the trial is going on. Rapamycin, there is a trial going on. SGLT2 and GLP-1 or glucagon-based therapy has entered because WHO has now accepted aging as a disease. It doesn't mean immortality, but living up to at least 130 to 150 years in a healthy manner. Is it possible? Yes, it probably is possible. Life expectancy was 35 years in 1930s. It's now near about 80. So it's probably possible to have a healthy living for at least 100 to 130 years. Now, with age, and remember the aging process starts after 30 years. So we normally say a person is elderly and you'll be retiring at 65, but the aging process starts at 30. So this is where the subcutaneous space fat starts going into the visceral space. And that's where the problem starts coming up. And that's why a simple thing like a liposuction is absolutely a waste. It just removes a little bit of your subcutaneous fat, makes you look in shape, but your visceral fat remains the same. Or to compensate, it even starts expanding. It might be bad for you. Now, what is interesting to note is that there are ectopic fat accumulation which happens into our system. I don't know, one slide is not opening. There's one more slide here, which I can see is not opening there, which is there is a concept called adipose tissue overflow. So when you have a certain degree of space in your system, in the visceral or in the subcutaneous space, but then the fat is still expanding, we are still becoming fat, they start accumulating in organs where they are not supposed to accumulate. For example, liver, for example, our heart. This is the data. You will remember SGLT2, huge question was how did it reduce our cardiovascular outcome? So Sundar Mudaliar came with this concept of ketones, the superfuel. It has flopped dramatically, recently showing there is absolutely no association with it. Hematocrit, erythropoietin, uric acid, everything, but nothing worked. The only plausible explanation standing today is epicardial fat. Again, this is an ectopic fat. Can be easily identified by echocardiography. And why GLP-1 has the best benefit when it comes to cardiovascular outcomes is because it has a maximum impact on the epicardial fat, followed by SGLT2, followed by statins. The superb statin thing that we talked about, you see all these benefits of the molecules are coming on top of statins. Why? Which means statins can reduce your cardiovascular risk by 10-20%, but it's a huge residual risk, which is not going down because of the epicardial fat. And the best molecule to do so is a GLP-1. Now, where is the fat getting accumulated? So you might be a healthy obese, metabolically healthy obese, or metabolically unhealthy obese. The biggest question, if you look here, these 2 individuals, I have stopped using that Professor Yagnik and that slide. It's been overused a lot. Let's look at the fat itself directly instead of those person and their faces. This person has a BMI of near about 25. Here is a BMI over 35. So traditionally, if you go by BMI, waist circumference, and weight, we'll say 35 is the guy who has maximum amount of adipose tissue. But do a DEXA, body composition, do an MRI, and you find the body composition here, fat is much, much more. 144 in the lower BMI, and it is around 130 in the higher BMI. So you cannot assess the increase in the visceral adipose tissue just by doing a waist circumference or a BMI or even just taking the weight. The way forward, how do we go forward? My last slide, and this is what I am discussing, writing a protocol with Dr. Seshadri now, I'll share with you, is can we do an MRI No, we can't. It is not a standard of care. We cannot catch hold of every patient in my clinic and say, let me see what fat you have by doing an MRI. It's an expensive procedure. Can we do a DEXA? A lot of our labs do have DEXA. A lot of our clinics have DEXA hospital, but these are for bone densitometry. You need the extra VAT software to do that. A lot of people will not buy that because it's still not standard of care. It still doesn't generate money for the clinics. Now, what else? HOMA IR, some people said, why don't you do HOMA IR? It's good, but it also takes into account the skeletal muscle insulin resistance, not necessarily visceral, used exclusively for epidemiological data. Individual patient-related data, there is still question mark, it's still not standard of care. I propose two things as a hypothesis. If you are, this can be a research thing, you can do it. Just normative data from India, 200, 300 patients will do. Can we find out with FIB score or fibroscan the amount of fat in the liver and corroborate with the visceral adipose tissue, say with a DEXA scan? Can we look at a simple echocardiography and look at the epicardial fat? These are the two simple things that we can do and find out what is inside. Again, these are not standard of care. This is not what the guidelines tells us. But the guideline also doesn't tell us what to do and how to assess. We have to find out of ways and means of assessing it. Since FIB score and fibroscan is a standard of care, why not start doing it for all our diabetes? That is part of the 2024 ADA guideline. Every single type 2 diabetic patient needs to be screened with a FIB score. I think this should be an adequate marker for your adipocyte volume. Thank you.